Now we are going to take the examination of a thyroid swelling. First, local examination of a thyroid swelling. Of course, we are going to do general examination first. Now we are going to show you how to do the local examination. Then I'm going to show you how to do the eye signs. The local examination of the thyroid swelling starts like all other swellings by inspection. The inspection, you are in front of the patient, at the front of the patient, at the same level of the swelling. You can sit down if you want to, so that you can be at the same level in front of the patient. I'm a little bit to the side so that you can see me. But actually, I should be facing the patient like that. Then I'm going to expose the patient, of course, from the head. The head should not be covered, but in this case, because this is for teaching, it is inconvenient for the patient, so we are going to keep her scarf on her head. And it should be, we should see here to the level of the nipples. For similar reason, this is not going to be done. But this is the traditional exposure in privacy, if you are in your private clinic or in the hospital clinic or so forth. So I'm going to now describe the swelling that I can see now. I can see a swelling at the front of the neck. This swelling, before continuing to describe it, an important special sign is going to be elicited, so that I'm going to make sure what is the anatomical swelling this is. So I'm asking the patient, first of all, to swallow. As you can see, the swelling moved up with deglutition. So I'm going to describe there is a swelling at the front of the neck which moves up and down with deglutition. This is the first thing I am going to describe. After that, I am going to describe that this swelling is mainly at the lower part of the neck, is bilateral. As you can see, the swelling is on the right side and on the left side. And in this case, because it is taking the whole thyroid gland, it is going to be a butterfly in shape. But actually, not all thyroid swellings are butterfly in shape like this swelling. If it is of one lobe, it can be an oblong swelling. If it is of the isthmus, it can be a rounded swelling. So not all thyroid swellings are automatically described as butterfly in shape. You have this is to describe what you see actually. This swelling is a butterfly in shape. We can see that the surface of this swelling here, maybe we can demarcate that this swelling is bulging, this swelling is bulging, and here is another bulge. I can see it, and I'm going to confirm it by examination, by palpation. So if I am going to describe the swelling, I'm going to say that the surface of the swelling shows nodularity, which I am going to confirm by palpation. But sometimes it looks smooth, and when you palpate it, you find the nodularity. Then in this case, it is nodular. We are going to look at this lower part of the swelling and ask the patient if I didn't notice it from the first time. I'm going to ask once more the patient to swallow and look if I can see the lower border of the swelling or not. Because this, if I can see it, it is one sign that there is no retrosternal extension. Yes, it moved up from here, and I can see that this part, I can see the edge of the swelling, so it is not having a retrosternal extension. Is this swelling superficial or deep to the sternomastoids? How am I going to test that? By inspection. By inspection, I'm going to place my finger like that, ask the patient to contract. ريحي. دوسي. You can see it decreased. ريحي. It increased. So if it decreased by contraction of the sternomastoid, then this swelling is deep to the sternomastoid. Then you are going to describe the swelling as the other swellings that we have described. Its size and the skin overlying. Here we can see a scar. We can ask the patient the history. What about this scar at the side of the neck? If you didn't get it from the history from the start, but we can see here a scar. But it is not a surgical scar, probably. It was for another reason. The rest of the skin is normal, as we can see, and there are no other swellings, and I cannot see a special other character here, which is practically pulsation. There is no pulsation here of this swelling. Now we are going, we have examined now from the front by inspection. By palpation, we are going to examine from the back. All right, now I'm standing at the back. How am I going to palpate? My two thumbs are at the nape. My hand is resting on the shoulder like that. The flat of the fingers over the lobes of the thyroid gland. What is going to happen? I will palpate each side in turn. If I'm palpating the right side, then I'm just steadying with my left hand, the left lobe of the swelling, steadying it, keeping it from being pushed towards the left side when I palpate with my right hand. So I'm steadying here, and actually only this hand is palpating. It's palpating the whole swelling here, from lateral to medial, from up to down. And what am I going to feel? First of all, of course, it is not tender and it is not hot. But after that, I'm going here to try to feel the surface of the swelling. Is it a diffuse swelling or a nodule or multiple nodules? I can feel here a furrow between this part and the medial part. So this is a nodule and this is a nodule here. So I feel it with the flat. And then what about these nodules? Are they soft, firm, hard in consistency? I can feel here that it is firm and homogeneous. The nodule is homogeneous and firm. The other nodule at the isthmus here in the center is the same. Can I feel the lower border of the swelling? I can feel the lower border here of the swelling. If I'm not sure about that, then I'm going to let the patient swallow, because the moving swelling can be felt better than a still swelling. ممكن تبلع ريقك? Yes, I can feel the lower edge of the swelling better now. Then I'm going to steady with the other side, with the right side, and feel the left side. I can feel here the nodule actually bigger than the right side. It is also firm in consistency, and I can feel it here, even movable over the trachea here. It means that it is very anterior, this part. That's why it is felt much better than the left side. I can ask the patient to swallow once more to make sure that it moves up and down with deglutition. What is I have seen with my eyes, I feel it moving behind my fingers. Then I will tilt the head of the patient a little bit towards the side that I'm going to examine and see if the sternomastoid, I can pinch it here and push the swelling like that away from it. Pinch the sternomastoid and push the swelling. This means that it is not attached to the sternomastoid here. The other side, pinch it and push it back to the other side. Then the sternomastoid is discrete here. It is not attached to the thyroid gland. Now, the suprasternal notch here, I can feel the suprasternal notch, but we are going to see now how to make sure that the swelling is not retrosternal. Here I can feel them not retroclavicular. Here in the center, I'm going to come from the front and see how to test for that. After that, you will have to examine the lymph nodes, all the lymph nodes, especially the jugulodigastric lymph node here, which drains the thyroid gland. So I'm going at the anterior border of the sternomastoid and my fingers like that, my thumb behind the sternomastoid and coming from up, down, along the anterior border of the sternomastoid, especially opposite the angle of the jaw here, to feel if there is a lymph node enlargement or not, and then moving down, down, down here. I'm repeating it on the other side. My other hand is steadying the head of the patient and moving down. I can feel no lymph nodes here. Then you can feel the lymph nodes at the posterior triangle of the neck at both sides at the same time, down, down, down. The supraclav by 2 fingers. You might ask the patient to shrug the shoulder up. Here I can insinuate my fingers behind the clavicle and there is no swelling. Then you are going to try to feel the pulsation of the carotid artery. We are going to come opposite also the angle of the jaw, anterior to the sternomastoid, and press backwards. We are going to do it one side at a time, not the 2 sides, so that the patient will not syncope. So here I can feel it in its place opposite the transverse processes of the cervical vertebrae. Actually, the carotid artery can be felt from the transverse process of C7 to the transverse process of C2 all along this distance. Here I am choosing to feel it above the level of the thyroid gland, almost at the transverse process of C3, so that if the carotid is displaced or if it is infiltrated, I can diagnose this. Now it is in its place and it is pulsating. If I cannot feel the pulsations here, I will try to find the pulsation posteriorly. If I cannot find the pulsations posteriorly, I will try to feel the superficial temporal artery. Repeat it on the other side. Here we can feel very well the carotid pulsations. So you examine the gland, you examine the lymph nodes, you examine for the pulsations. Of course, now we had to examine the scalp. If without a covering, you move your hand over the scalp to see if there are other swellings of the scalp. This can be metastasis from follicular carcinomas. And then we are going to come to the front here to see 2 things, the tracheal shift and the retrosternal extension. We have seen by inspection the lower border of the gland. If you are in a doubt, then we are going to feel the lower border with 1 finger like that. In order to feel it properly, we have to be at a level here, and then we put 2 fingers over the clavicle, the middle and the thumb over the clavicle, and the index finger is actually not like that because this could be painful to the patient. It must be hooking the suprasternal notch, gently hooking the suprasternal notch. My other hand is at the head of the patient. If the head of the patient is very much extended, then the strap muscles are very taut and the investing layer of cervical fascia is very taut. Then the trachea is far away and I cannot feel it properly. But if I flex too much, actually these muscles are not taut, but the trachea is too much backwards. So actually I start here feeling the suprasternal notch and little by little flexing the head till the best feeling of the tracheal rings here, till the best feeling of the tracheal rings. And then I'm hooking like that, the suprasternal notch. I am feeling the trachea rings behind my finger, so there is no retrosternal extension. At the same time, the trachea rings are behind my tip of the fingers, not at one side of it. So if it is the trachea at one side, then it is shifted. Now, if I am not capable of feeling this like that, very good, I can ask the patient to swallow. In this case, the trachea rings will move, and I can feel a moving trachea better than a still trachea. تقدري تبلعي ريقك مرة؟ Yes, I can see it moving behind the tip of my finger now. Then I am sure now that this patient is not having a retrosternal extension. The trachea is not shifted to one side. Then now we can test if this swelling, the thyroid swelling or the goiter, is hypervascular or not. If it is hypervascular, you might feel a thrill. To feel a thrill, we just put the flat of the fingers lightly over the lobe of the swelling or the enlarged lobe. We can put it both sides like that. We can not, there is no thrill here. If there is a thrill, especially if it is a diffuse enlargement like in primary thyrotoxicosis, which is hypervascular, we can even sometimes hear the murmur. Okay. There are a group of signs for a toxic gland. The first of these, of course, the symptoms are suggestive of toxicity. If you are taking a proper history, you are knowing if this patient is having symptoms suggestive of toxicity or not. You are going to test for toxicity by eliciting some signs. The simplest of all, of course, is the resting pulse. You take the hand of the patient here and you feel the hand of the patient. All right, then you are going to test for the signs of toxicity. Of course, if you took the history properly, then probably you know now that the patient might be having signs of toxicity. This patient does not have these signs, but I'm going to elicit them to show you how it is done. First, you are going to take the hand of the patient. You feel the hand of the patient. It is not sweaty. If it is sweaty, this is suggestive that the patient is having toxicity. Of course, then you go to the radial pulse and you count the radial pulse and you feel if this pulse is regular or not regular. Sinus tachycardia, ectopic beats, and so forth. This all might show cardiovascular effects of thyrotoxicity. There might be hyperdynamic circulation by feeling the pulses over the arm here, the forearm. Then you go, of course, to the eye signs that you all want to know, how to test for these eye signs. First, we look at the front of the head. Here, at the front of the head, there are corrugations or loss of corrugations. It is a collective thing, actually. You might not see in the young patients the corrugations like the older patients at the front of the head. But we see here there are few corrugations because the patient is young in age. Then we can see, we ask the patient to open her eyes and wrinkle the forehead up. تقدري ترفعي حواجبك عادي. She can wrinkle her eyes. Then we look at the eyes which are there bulging or not for exophthalmos, and to do this we stand behind the patient and move the head backwards until we see the eyebrow with the maxilla here, maxillary prominence, and the eye should be opened. And see if you can see the cornea or not.